All right. Well, welcome everybody to Grand Rounds. This is our special dream speaker today, Dr. Polly Parsons, who was selected by our residents to come and give Grand Rounds and be a visiting professor. And I'm delighted to introduce Dr. Frankie Garofalo, one of our residents, to do the introduction for Dr. Polly Parsons.
Thanks, Dr. Schnapp. So my name is Francesca, or Frankie Garofalo, second-year internal medicine resident, and it is my pleasure to announce Dr. Parsons as our 2024 Dream Speaker. Dr. Parsons was selected by our internal medicine residency to be our Dream Speaker because of her extensive leadership in the field of internal medicine. She received her bachelor's degrees in biology from Harvard University and then went on to pursue her medical degree at the University of Arizona. She then went on to pursue internship and residency at the University of Colorado, followed by a research fellowship at the National Jewish Hospital. After that, she became a pulmonary and critical care fellow, and then on the faculty at the University of Colorado until 2000, when she moved to the University of Vermont to become the division chair of pulmonary and critical care medicine, as well as a professor of medicine. In 2005, she became the interim chair of medicine at the University of Vermont, followed by the Abaddon chair of medicine in 2006. In 2022, she was named the president and CEO of the Alliance of Academic Internal Medicine, the first woman to achieve this. She's also a past president of the American Thoracic Society. Dr. Parsons has had over 170 published articles, chapters, and reviews, and has received many awards. One of the other things I learned in addition to this about Dr. Parsons is that she led the University of Vermont through a cyber attack in 2020, in addition to the COVID pandemic. One of her medals is the Edward Livingston Trudeau Medal from the American Thoracic Society, which she received in 2021, which is given to those who have made lifelong contribution to the prevention, diagnosis, and treatment of lung disease through leadership in research, education, or clinical care. While president of the Alliance, Dr. Parsons has continued her work as scientific director of the Parker B. Francis Foundation, which funds junior investigators doing research in pulmonary and critical care. Today, Dr. Parsons will be presenting her grand rounds on acute respiratory distress syndrome and a career, lessons learned from the past. Afterwards, from 9 to 9:30, there will be a chance to come up and ask questions individually to Dr. Parsons. And without further ado,
Well, thank you for that amazing introduction. If I go home and tell my 2 adult sons that I was the dream speaker, that's going to be the meme for a really long time. So I might not announce that to them. So thank you all for inviting me here. Thank you, Frankie, for arranging it for sure. And also a lot of thanks to Catherine Vaughn, who put everything together to make sure that I actually got here. And actually I'm here right this second. It turns out, for those that may not know, Catherine actually previously was a school teacher, so she's got a lot of experience with kindergartners, so I was not a big problem for her, but it worked out well. So when I was asked to come and give a talk, I kind of looked at the areas that the residents were interested in. It was more about careers and other things, which sounded great. Then I asked Lynn Schnapp, I'm like, so Lynn, just give me an idea. And she's like, got to talk about science. So I'm like, well, there's a good combination. So this is going to be a talk that's a little bit of both, and we'll see how it goes, and I'll be happy to take questions as we go along. My only disclosure is that you've seen my new position. I am the section editor, was former the editor-in-chief of Up to Date, but I'm not talking about anything related to that today. These are the learning objectives. It was a little hard for me to put together learning objectives for this specific talk, but you can see them up there, and we'll see how I do with that. So I want to talk a little bit about my career. I'm not really great about talking about myself, but we talked about it last night at dinner. It was a lot of fun, and sort of thinking about how do people get to where they are. So I want to make it really clear that I've never had a defined pathway. So it's not like I grew up and said, I'm going to be a doctor and then I'm going to be a chair of medicine. It's all sort of been a little bit of serendipity and chance. As you can see, these were indeed my early career goals. I'm dating myself. In 6th grade, if you asked me, I wanted to be a TWA stewardess. It's before they were called flight attendants. Thought that traveling around the world would be awesome. When I was in high school and going to college, I was going to be a lawyer. Then I was going to be a field biologist. I'll show you some of that. When I was a medicine resident, I had absolutely no idea what I wanted to do, which is why I did a year of research between residency and fellowship. And as a pulmonary fellow, I actually thought very seriously about going into private practice. So my research started with monkeys. This was going to be my career. For those of you who don't know, this is a spider monkey on the right, and that's a slow loris down below. And I trained monkeys to swing on treadmills, with the idea being that brachiation, a form of locomotion, which is like a pendulum, would be a very efficient form of locomotion. I actually got to do research at a field station at the university I worked with. You can see, and I created data, which is pretty amazing if you think about monkeys that just like to drop off things. And I got sent to Panama to the field station to pretend to be Jane Goodall for a while, which was awesome. It turns out brachiation is actually a very expensive form of locomotion. That's not the focus of the talk today, but of interest. But it offers a lot of advantages. So the other thing I discovered, not only about the issues related to brachiation, is that number one, I was not Jane Goodall. Clearly, I was not going to be spending my life in the jungle watching monkeys. Unexpected results oftentimes offer opportunities. And for me, it was really a truly understanding of the generosity of mentors. This was the person who was a full professor at the college I went to, who basically took me under his wing, let me do this extraordinary research, sent me to Panama, believed in me enough to do it. And then when I said, I was ready to go to graduate school, things were kind of set up. I'm like, I don't think that's for me. He helped me, figure out a different career path as well. When I was a fellow, I moved actually into more basic research in a research lab with Peter Henson. Peter actually is a veterinarian by training and a PhD, a very prominent basic scientist. And I did a fair amount of work. I started a little bit using bronchoalveolar lavage fluid, looking at different factors. I might have actually found interleukin-8, but I didn't know what it was, so I never got very far in that. And I did a lot of work, and I was in this research lab that was pretty intensive. And I concluded I'm really not a basic scientist, but this person was an extraordinary mentor for me. And I think the reason I show this is because Peter doesn't look like me. Okay, Peter is not a senior woman. Peter is a veterinarian by training. Peter's a basic scientist, but he continued and still continues to be an amazing mentor. So mentors don't have to look like you. They don't have to be like you. They just need to connect with you in a way that's unique. As I was in the lab and working a lot, I kind of was like, the big assumption here is we're trying to study acute lung injury. And there's a lot of work in animals and in cells, and they all look pretty similar. And I'm in the ICU taking care of patients, and they look really different. So this concept that, normal animals look like patients, and therefore you can study back and forth, I was a little confused by. So the aha moment for me was I was sitting in a research meeting going, wait a minute, my patients don't really look like Sprague Dawley rats or things in test tubes. They all come with other conditions. They all come with different attributes. And all of a sudden, I had something unique to offer to the research group, and they had something unique to offer to the clinical group. So I became a translational scientist. It turns out the concept of translational research, I didn't really realize this, didn't really enter the lexicon until the 90s, when actually it was big in the cancer world. But before it, people weren't called translational scientists, but it's an ability to bridge between the bench and the bedside. And that was my unique, I'm like, I've got this. Now I understand sort of what to do and where to go, whereas before I'd been floundering a little bit. So I really focused on ARDS, and we're going to talk about that today, but the main focus of this is not to tell you about all the science of ARDS, but just to show you how things progress. So ARDS was a huge global problem even before COVID. It's something that had a significant incidence with a significant mortality associated with it. It was first described only in 1967 when 12 patients were noticed to have many things in common. And that was sort of the beginning. You can see the initial 12 had sort of clinical diagnostic criteria, the things that they had in common. And with this, it started a whole launch of us looking in the ICU for patients look differently. I was not in the ICU in 1967. I want to be clear about that. And at that time, and even when I was in training, which was later, we had a syndrome that had an extraordinarily high mortality. We quoted a mortality of 60 to 80% in those days, and we threw everything but the kitchen sink at these patients because we had to do something, right? They were critically ill. We weren't sure what was causing it. We didn't understand it. So we did all sorts of things. We used massive doses of steroids and then finally studied it when we thought maybe it would be a good idea to see if it actually worked. We used very high tidal volumes. People were turning up PEEP as high as it would go and covering over PEEP valves so it would go even higher. And then we kept changing and modifying the definition, thinking maybe if we could identify people better, we could do things. And over time, there was sort of this, if only there was a troponin for ARDS. Now, troponin's not perfect anymore, but when it first came, it was like, oh, once again, the cardiologists beat the pulmonary world because they can like do a blood test and then they know if somebody had a heart attack, whereas we don't have a blood test to tell us who has ARDS, who's going to get ARDS or anything. And so my career was focused on looking at biomarkers in acute lung injury, trying to identify something that would both tell us who was going to get the syndrome and maybe who actually had it, because it was a little hard. Biomarkers actually were not a term until the 1970s. Now you hear that word all the time. And they really started to increase in the 80s and 90s. So we were on a train about then that was a fairly common one, desperately looking for things that could mark and measure. Biomarkers have a lot of things they can do. They can diagnose disease, they can predict it, they can identify patients within what looks like a very heterogeneous clinical phenotype. They are used for diagnostic for disease severity, for prognosis and outcomes, for monitoring or using surrogate endpoints for clinical trials, for therapeutic decisions, and also for either elucidating or confirming pathogenesis. So they're very useful depending on how you use them and how you think about them. There was a working group back in 2001, so think about that wasn't that long ago, at the NIH where they actually tried to define what a biomarker was because we were all using the term very differently. And you can see it's a characteristic that's objectively measured and evaluated as an indicator of normal biologic processes, pathogenic processes, or pharmacologic responses to therapeutic intervention. It doesn't have to be a blood test. It can be an X-ray or a radiograph. It can be all sorts of things. So I was on the search for the Holy Grail, and as I was doing it, these things came up. So I found the one on the right in somebody's talk on the internet, which is why are so many biomarkers discovered, yet so few approved, or Mama, don't let your kids grow up to be biomarker researchers. So I was not the only one who was flailing around trying to find it. And then in JAMA back in 2011, this article about the thin line between hope and hype in biomarker research came out, really pointing out that a lot of things that I'm going to show you, which is we were measuring biomarkers and we'd go, this is it. And then it would get studied later. And it's like, that wasn't it. So it was a complicated area. The search was really confounded because at the time in ARDS, there were a few centers doing research in this area. One was at the University of Washington that Lynn Schnapp knows well. Denver, where I was a big one. And we were all doing these measurements and we were all getting different results. And it was getting really frustrating because it would be like, it's definitely this. I've measured it, I've got it. And the people in Seattle would be, that's not what's happening here. And we were just getting frustrated. And the question was why? And I think this is one of the most important questions in medicine. And for residents and students and fellows and everybody, never be afraid to ask why. So if something's kind of moving along and you're like, why does that work? Or I don't understand why this looks different. That can be really game-changing for our patients, for research and everything. It turned out there were a lot of reasons, and I'm going to go through them. This is the list of the reasons. There are all these different things that we were doing somewhat differently or we'd not clearly defined. So the definition of ARDS was initially a big one, like, what is it? There was this concept of, I know it when I see it. Well, we were all seeing different things. So there was a time, if you showed us all several X-rays, we wouldn't even definitely agree on the reading of the X-ray as to whether or not is this ARDS, yes or no. Early on, there were many evolving definitions. The first three were the lung injury score, the modified lung injury score, and this consensus conference definition. We actually looked at it in Denver. I did this with one of the fellows that I was working with at the time to see if we were even identifying the same patients. So, was that part of the problem? Was Seattle using one definition? We were using a different one, et cetera. It turns out as long as you use these definitions in patients with a clearly defined at-risk diagnosis, and I'll show you that's a problem, they worked relatively well. There was a reasonable overlap amongst them. Eventually that evolved to what's called the Berlin definition, which is until this year, the one that everybody was using. But it's interesting, people were still saying, I know it when I see it. They really weren't necessarily following this definition. People interpreted it differently. You know, the timing is sort of a variable that's hard. You got to read the chest x-ray and decide, et cetera. The other problem that was really confounding is the risk factors. So what's sepsis? Like, what is the definition of sepsis? And when we first started, we all used very different definitions. Aspiration of gastric contents. Is that a little? Is it a lot? Trauma. Is it all trauma? If somebody has head trauma, is that neurogenic pulmonary edema? Is that ARDS? So this concept of what are the risk factors and how you define them was really creating a lot of variability in how we were looking at things. And the other interesting thing is I worked a lot with the University of Washington group. Near drowning was a problem in Seattle. It was not a problem in Denver. So I was at a major city hospital where we had a lot of trauma patients and sepsis and others, but not some of the diagnoses they had. The other thing I want to point out, especially to the residents and fellows, is if something doesn't fit, start asking questions. So we were in an ICU one day and we saw this x-ray in a young woman, and she had no risk factor we could figure out, but it certainly looked like ARDS to us. I mean, it was classic with no risk factor. And she had some hemoptysis as well, and we were confused. And then somebody else came in a few days later with the same symptoms, and we're like, we just don't get it. So some friends came in for the second patient, and we were talking to the friends, and we're like, you know, we're confused. She's coughing up some blood. He's coughing up some blood. We're not really sure what's going on. And they said, well, you know, he smokes crack. We're like, what's crack? And he's like, and everybody knows that if you smoke crack, you cough up blood. We're like, great, we're not everybody. So it turns out we subsequently had 2 more cases. And all of a sudden we were like, oh, so this looks like ARDS, but it's probably not the same pathogenic mechanism. And so we actually wrote it up. And for a while, despite other things I had done, I was known as the person who, quote, wrote about cracked lung. But again, if something doesn't make sense, ask about it, because you may well contribute something pretty exciting and new. The other thing we started really talking about, and as clinicians, we all know this, but when you're working with all the research world, this really confounds it, is patients are not all the same, right? You sit in the ICU and you look and you've got, okay, I have 4 patients here with ARDS. This person was a young, healthy male. This person is an alcoholic, for example, or abuses alcohol. This person has diabetes, all these different things. They did not come in all completely normal and healthy and start with the syndrome. That concept of heterogeneity, we started talking about early, and it did really confound research and made it hard, because prior to that, we would just say all ARDS patients are the same, so we're good to go. So we showed early on that even if patients who had ARDS, if their risk factor was sepsis versus trauma, and we started to measure biomarkers that looked different between those groups, we showed it in terms of mortality differences between the groups. And actually, I was in the research lab I was in, we used to use normal healthy donors for blood to look at neutrophil function and other things. And we liked the ones that responded a lot to endotoxin, because that really helped our studies. And the ones that didn't respond a lot, we just didn't ask to come back, which was a major miss in the beginning, because that's a huge opportunity to discover, to really look at heterogeneity. It wasn't until fairly recently that the word heterogeneity got used a lot and really was accepted in this area. There was a big lung conference in 2021 with it specifically in the title, and in 2022, the NHLBI finally put out an RFA to specifically study this particular concept. We started working on it, and we realized, and many others have contributed to this now, that lots of factors contribute to heterogeneity and impact the development and outcomes of ARDS. So now you're looking at a whole world of ARDS patients, and you're like, each one may be unique, or you've got to classify them some way. This is the current list. It'll continue to be added to, and I'll just show a couple of early examples. So we looked at patients who used a substantial alcohol, and we looked at those with a past history of a substantial alcohol use versus a negative history, and found that the incidence of ARDS was increased in patients with a history of alcohol abuse. And that's led to a huge amount of basic science research under determining the mechanism, et cetera, that Mark Moss and his colleagues went off and did. And then we found that the incidence of ARDS was decreased in diabetic patients with sepsis. So now it's like, wow, there may be different mechanisms to the disease. Patients aren't all the same. How do we think about it? And there were many other studies that look similar. The other thing we figured out, the reason we were all getting different results, was the concept of study design. Like, what's your control group and what's the timing? So on your left, I found the holy grail. This is interleukin-8. I measured it in normal subjects, and I measured it in patients with ARDS. It is dramatically different. So it's great. If we measure IL-8 in patients, that will diagnose ARDS, right? So my lab tech and I were joking, and she's like, "Yeah, I think we have to do some more measurements." I'm like, "Yeah, unfortunately, I don't think we can stop." So we had a biobank that we had created of patients who were at risk for the development of the syndrome. So as soon as somebody was identified as being septic, or they came into the emergency room and having sustained trauma, for example, we would run down, get consent, and draw blood. And indeed, if you look at people who are at risk for the syndrome, who do and do not go on to develop it, IL-8's up in everybody, and it's not predictive of who's going to get the syndrome or not. So if you publish the first study, it looks like cytokine storm, okay? If you publish the second, it's like it does not differentiate your patient groups. The other thing that I really want to hammer on is sample size really matters, okay? We oftentimes we're in the ICU, we're in a situation, we don't have a lot of patients, we're only going to study a few. In the beginning, we were all doing small studies. Each center was small, it was doing its own thing. We never were put together. This is a very early study, and for the residents in the room and probably most of the faculty, you've never had the privilege of putting your dots individually on a graph. That's what it looks like. I had to dig this up. And so what we did is we would identify potential biomarkers from animal models. We'd measure one biomarker, one at a time. We do it in a small study. This one's not a huge study. It's patients at risk with and without ARDS. We all assumed that they were the same. There was homogeneity, not heterogeneity. And that kind of gave you conclusions that were fine in one center, but not necessarily translatable anywhere else. Finally, in 1994, the NIH actually funded the first ARDS network, which was now 10 sites around the country with a coordinating center that over time could enroll more than 2,000 patients in clinical trials. This was a game changer for critical care. It really meant that we could do large clinical trials, not single center anymore. It was interesting, this network was initially established to only be a clinical trials network to specifically study some drugs or potential interventions, but with no financing at all to look at mechanisms. So we weren't going to draw blood from anybody. We weren't going to store anything. I worked with a person from the NIH and a very senior investigator, because I actually was junior in this group. And I was like, well, how are we going to know if something works or doesn't? So if we give patients a drug and we get a negative outcome, is that because we didn't give them enough? Is that because it didn't work like we thought it would? Like, how are we going to know? So the other secret here is the NIH actually then, with additional information, provided additional funding to this network to specifically be able to gather samples and store samples. So the NIH is not a giant black box that has no feeling or no sense of the future. They really then changed the way they thought about these networks and actually provided resource for this network to do something it was not originally planning to do. And that has resulted in tremendous opportunities in terms of research studies. So although there are lots of larger trials, this is just a laundry list of many now that have been tried in acute lung injury. So far, we have no therapeutic intervention that's worked, but at least we're doing it in large heterogeneous patient populations, so we're starting to get an idea of pathogenesis in others. It's important to know there's always hope. There's still lots of trials going on. But if you look at these numbers, okay, in terms of clinicaltrials.gov, these are not all being done in large centers. A lot of these are tiny little studies. And so you want to think about that. Like if you do a small study and your patient population is not really homogeneous and tight, are you going to be able to get enough information to actually make a contribution? The other big thing is what to measure. So we were measuring everything. Anything that looked at where it came about in animals, any new cytokine that was identified, we measured it. This is actually a page from a very early research grant that was submitted. The NIH decided that what should happen is there should be ARDS score centers, and those score centers needed to have a clinical project or some relation to the clinical world, which was unique at that time. So this is what we measured. And as you can see, things were up, things were down. We had a hypothesis. But the thing I actually want to point out here is not on this slide. So remember I told you about Peter Henson, my mentor? When this grant was going in, I was barely a new faculty member. I think I was an instructor, probably got promoted to assistant professor during this. I was the only one doing anything clinically related to ARDS. So I was the one in the ICU doing this work, doing the translational work. So I was the only one that actually had the data. The grant was very important to the institution, and they made a decision at the high level that only senior investigators would be on the grant and somebody else would be given my data, and they would write that section and they would be the PI for those sections. Peter said no. Peter said, that's not fair. You can't do that. And they're like, but she's really junior. And he's like, we're going to make it work. And he stood up. I was like, but give it to the senior person. Don't make me do this. But he said, no, he said, that's hers. You have to let her do it. It's back in the day when the NIH used to send a study section to your site. So you rehearsed for days. You had to stand up in front of a group and present your research. It didn't just get sent off on paper. And so the person before me was very senior. He stood up and he flailed. It was bad. I'm like, oh, I'm not doing this. And actually another person who was a very senior person who was on the study section said afterwards, he came up and he said, I know you're next. There's a break. I need to talk to you. He took me outside and he said, he just started asking me really hard questions about my presentation and he grilled me. And I'm like, oh, this is bad. And finally he stopped and he said, you're good. And I'm like, what was that? He goes, I didn't want you to have the experience the senior person did because you're junior. And if you'd flailed in front here, I bet you would have quit medicine. He said, you're good to go. You've got this. So he'd already asked me the hard questions. By the time I got up, I was like, go ahead. It's okay. So again, very lucky that somebody looked out. The other big thing is, what do you do? How do you do more than one measurement? So we had all these measurements, but how do you analyze them? And that's where Carolyn Culfey, who's now at UCSF, came in. And she really started to do some very creative work looking at risk classification using multiple biomarkers and has now developed latent class analysis where she's identified multiple phenotypes. And this was a game changer for us because all of us had all these unique measurements and really putting them together in ways that identified different patients was a huge advance forward. And I was on the original paper and I almost understood her analysis. I had to keep being taught multiple times. And she's gone on, like I say, and done amazing things. So what that did is, if you think about this in terms of a picture, is think about the big circle is everybody that you look at in your unit who, quote, either has ARDS, might get ARDS, they're all different, right? If you can identify a series of biomarkers that can separate them out into whatever groups you choose, you could get down to a relatively homogeneous group. So in here is the hyperinflammatory phenotype who also smoke cigarettes, for example, but then has probably, they're very homogeneous. So now you can study that group and you might be able to develop therapeutic interventions for them specifically or pull them out specifically for clinical trials. So whereas before almost everything we did was in this giant group with all of those differences, you're starting to be able to segment people out, which really helps a lot. The other big thing we were confounded by is where were people measuring things? So there's, if you have a patient, there's blood, there's bronchoalveolar lavage fluid, there's urine, and they're rarely biopsies now. So that's what we had. So some people were measuring things in lavage, some were measuring things in blood, some people measured things in urine. And sure enough, we all got different answers, okay? So I just circled a couple. So for example, interleukin-8 is elevated in plasma and bronchoalveolar lavage fluid. There's also just lung fluid that you can pull. It was different in that. You can see that in some of the others, they're elevated in plasma, decreased in lavage. So where you measured it made a big difference, which is part of the reason we were getting different results. The other thing we discovered very early on is the assay you used made a big difference. We were all using different assays. So one of my colleagues, we were convinced that we had the right answer with TNF for a while, but we had very different results. So we exchanged samples between Seattle and Denver, and I ran them using different assays. And as you can see, these are the same samples run with two different methods, and you get very different results. So understanding how things are measured turns out to make a big difference. The other big one is the impact of clinical care. So when the ARDS network started, we're all sitting around trying to decide what we're going to study. And there's one person who's very famous who was like, we need to study drugs, which is what we started with. And then people were talking about the ventilator, like we should study the ventilator. And a very famous person said, we can twiddle the dials all we want. We're not going to change anything. But if you really feel like you got to study the ventilator, sure, let's study the ventilator. So we studied the ventilator. So The study was basically what, higher tidal volume versus lower tidal volume. It's the one you all know now, 6 mils versus 12 mils. And lo and behold, it was different. I mean, this was the first intervention in acute lung injury, ARDS, that actually changed mortality. This was huge. And the really exciting thing was, because the NIH was not a black box, because they provided extra funding, we had a repository of samples, so we could show that there was a big difference in what happened with mechanical ventilation in terms of inflammatory markers. So now we had a direct relationship between what we were doing clinically and what that did to the patient, not just with their oxygenation, et cetera, but what was it actually doing in terms of biomarkers. The other thing is there's still no cure for ARDS. There's no therapeutic intervention except lower tidal volume, basically right now. There are many, many studies that do show that mortality from critical illness is decreasing, which is great. And the question is always why. Many of these studies are indeed in ARDS network centers where once something is decided to become like low tidal volume ventilation, you believe in, so you do it. You can see why in those centers it may go down. And so we always think, great, we do these clinical trials, we transition practice, everybody accepts them, and they actually do it. So it turns out that may or may not be the case. So the low tidal volume ventilation study came out in 2000. It was widely regarded as a very positive study. There was very little blowback about anything related to the clinical trial design or anything else. This was, people believed it. They thought it was scientifically accurate. There were multiple different statements that came out in guidelines saying we should do it. And the piece I want to remind everybody is it was based not on, looking at the patient, I think they weigh about this much, so I'm going to make their tidal volume X. It was based on using a predicted body weight for all patients. But we all believed in it. So I went from Colorado to the University of Vermont. And we believed in it, the University of Vermont. The MICU director strongly believed in it. I certainly believed in it. Our faculty believed in it. And we were sure we were doing it. We were positive that everybody in our unit, because we are awesome, was on low tidal volume ventilation, okay? Turns out that wasn't the case. So as you can see, we did, the pre-group where we looked in the past was on higher tidal volumes than post. So we were moving towards a lower tidal volume, but we still had large numbers of people with large amounts of tidal volume. And the big question was why? Like, we got this. We know what we're supposed to do. How many times have we known what we're supposed to do? We're sure we're doing it. And then somebody goes, you're actually not. Well, first of all, people weren't recognizing ARDS, okay? So you look through the chart and you went and looked at the x-rays and you're like, this person meets the criteria, but it was never noted clinically in the chart, okay? The other thing that happened is we were indeed going, I think the patient weighs about this much, and so this tidal volume should be this. We weren't measuring the patient. So you got to take a tape measure and actually measure the patient. And those measurements weren't in the chart. So it's simple things like that. There was also people, occasionally somebody didn't believe in it. You can deal with those. It's simple things like that. And that has been shown over and over again for low tidal volume and for everything else we do in medicine, right? Think about aspirin for people with cardiac disease. Think how long it took us. Think about every intervention. So even though you're sure you're doing it and you are beyond positive you're doing it, probably not. This was not my research, but this is another example. So early studies back in 2013 showed that in severe ARDS, prone positioning appeared to offer a fairly significant benefit. Now, prone positioning, for those of you that grew up in the pre-COVID era, seemed complicated, okay? It was fairly complex to turn the patient over. They were all ventilated, non-mechanical ventilation. It was hard to maintain it. There were a lot of issues with it. But the data worked strong for prone positioning, especially in patients with severe ARDS. And you can see it here. And multiple meta-analyses have continued to confirm benefit. So there was a study done by others, not me, called the SAGE, the Generating Evidence Study for severe ARDS, where they looked at a large number of patients in 2016, 2017, way after prone positioning was shown to be good. And they looked at a whole lot of things and said, so what's happening with these patients? And that's now across 29 US centers, not just at the University of Vermont. We weren't the only ones not doing it. So low tidal volume ventilation, they used a lower than 8, which is a little low. So it gives you probably a reason it's not 100%, but it's still only 31% of people are on, quote, the real low tidal volume ventilation. And prone positioning, I want to point out, was less than 6%. So again, a therapeutic intervention that we believed in, we had good evidence for, and it's 6%. And then there was COVID. COVID changed everything. And I want you to remember what I've already been talking about and kind of where we were before COVID. COVID not only took us all by surprise, but it significantly increased the volume of patients we had, right? I mean, we all of a sudden went from seeing an occasional patient with ARDS to thousands upon thousands. And it happened fast. And I'm showing this timeline because it becomes important later. So in the United States, as much as we'd like to forget all this and it's all a blur, the first case was discovered and publicized on January 21st of 2020. February 3rd, public health emergency called. March 13th, it was declared a national emergency. And the other piece I want you to notice on March 30th, so literally 2 months, the FDA put in an EUA for hydroxychloroquine based on sort of general, we want to try something. Vermont, I'm sure, looked like here and everywhere else, okay? We, on March 13th, there was a governor's emergency order. We did not have a case yet at that time. By Sunday, March 22nd, the entire Department of Medicine had been mobilized. We had succession plans for everybody, trying to pretend like, hey, if you get hit by a bus, who can cover, as opposed to the horrible thought, which we're all worried about, right? We had substantial coverage planned for every possible scenario. Everybody was all hands on deck. By April 4th, we had already set up a huge gymnasium with hundreds of beds, and the Vermont National Guard had helped set up, again, about 400 beds at the fairground. So you all did this. We all went through this really, really fast, and it was really scary. We had a disease that we knew was lethal. We also had a disease that all of a sudden, all of us were potentially susceptible to. So a really scary time in medicine, going really fast. And if you think about what we thought at that time, there was a lot of back to what I talked about early in ARDS is we have to do something, right? We have to do something. And you can understand why we all thought that. So here are some quotes from right around there. A senior clinician at University of Vermont in June of 2020 said, this is just bad ARDS. Why does everyone think it's something new? Not that it wasn't scary, not that it wasn't overwhelming, but it's like, wait a minute, back in the day, we've seen this before. Another senior clinician, not at University of Vermont, nationally said, this is war, peacetime rules don't apply. We don't usually talk about that in medicine, right? We're usually a little bit more like, wait a minute, let's sort of think through things. Let's be a little careful. And another said, it's just deja vu all over again. And that's something that's been attributed to Yogi Berra, if all of you don't know it. And all of us were in this, we have to do something. So we did do a lot. People did extraordinary things. People took care of patients in a way that we had never taken care of before. We really rallied as a healthcare system, and it was extraordinarily hard. So we, for example, came up with, we started a number of new therapies that led to a new potential definition of ARDS. This is the one that just came out. This is a consensus definition of a proposed new definition. I'm not going to go over the details, but I want to highlight some of the reasons it changed. So first of all, with COVID, we started using a lot more high flow nasal oxygen, right? That wasn't in the previous definition. You needed to be intubated and ventilated. And so now a therapeutic intervention comes along that we start to really adopt and use, so you need to change your thing. We also weren't doing blood gases on everybody during COVID. We didn't need to anyways, and so a lot more work using pulse oximetry and really validating how that did or didn't work. Using ultrasound, because we couldn't always do lung imaging, other modalities of lung imaging. And also, this definition really helps for those places that are resource limited. So during COVID, even some of us were resource limited, right? I mean, there just wasn't, we didn't have everything for everybody, but in many countries of the world, there just aren't chest CTs and readily available chest x-rays, et cetera. And many people are not ventilated. So really trying to incorporate this new world that we had of ARDS and try to say, can we better define it, et cetera. Now, like before, every new definition should be looked at because the question is, does this identify the patients that we previously identified, or are we incorporating new patients, and how do we think about that? So there's a really great editorial written, that somebody here might be one of the authors of, that we sort of pointed out some of these issues. So there are a number of issues actually with pulse oximetry. There's several with ultrasound still. There'll be some changes in what's going to come out with epidemiologic research. If we change the patient population significantly, there may well be great or not great impacts on clinical trials. So if we can enroll patients earlier, that might be good, unless we're enrolling a lot of patients that really don't have ARDS. And it may well increase the heterogeneity. So this is another example of progress. We've had a huge pandemic. We did a lot of things differently in the ICU. How do we incorporate that? But at the same time now, how do we step back and not say, this is definitely the new definition? How do we go, is it the right definition? And what pieces of it can we study and make sure who we're identifying with it? And then say, is this different than who we identified before? So if we do get information from this patient group, can we compare it to previous patient groups? The other thing that I was really, really excited to see, it was like, oh, we made an impact. This is not my data, but initially when people started with COVID, it was like, it's a cytokine storm. Everybody has all these cytokines. I'm like, yeah, that's ARDS. And finally, people were actually doing measurements and comparing different controls and different groups. So they weren't comparing people with COVID to normals like I did a long time ago. They're actually using critical care comparisons, and they were looking at, ARDS from non-COVID, COVID ARDS, and really thinking about biomarker measures a lot more broadly than we had in the past. So we did take some of the past history, and it was utilized during this by other investigators. The other thing is we actually started to do evidence-based medicine. It was great, right? I mean, prone positioning, we were like all about. All of a sudden, we were doing it in awake patients and did a tremendous amount of work there, really adopted that, which had been previously shown to work. So we went from a prone positioning kind of utilization of about 6% to when did a multi-center analysis of patients with COVID, 76% of patients with significant COVID now actually were getting a therapy that we had, or an intervention that we had previously shown worked. So we actually practiced evidence-based medicine, even though it was a crisis. The other thing that we did a lot of, and I use the term we pretty generally here, so not I, we used ECMO, right? We went from pre-COVID, where the data were constantly being sort of criticized, the studies were small, there were a lot of issues with them. I put a couple of the issues down there, to we're utilizing it a lot. Again, we needed to do something. We needed to bridge people. We needed to get them to other institutions. We did everything. We didn't do any randomized trials. We just did a lot. We were doing it for longer. So early on, it was sort of used as a bridge to get somebody to something else. We were doing it for longer because you weren't transporting patients, you were keeping them. And there's actually a suggestion early on that there might have been some increased mortality associated with it. It is not an easy procedure. There are lots of side effects. And so because we did a lot, the most recent guidelines from the European Society of Critical Care Medicine actually do recommend that you use ECMO in both patients without COVID and those with COVID, but they very carefully explain that this is not based on spectacular evidence. And in the paper themselves, they say because there never will be a controlled clinical trial. We've gotten so far down the road. Fortunately, we have enough data and enough experience, we can start to evaluate it, but we're not probably ever won't get to a clinical trial. And sometimes that's the way things evolve too, where you do things, it looks like there's benefit, and when you go back and look collectively, you can look at a specific group and say, yeah, overall, it looks like that was the right thing. There are a million caveats with this. You need to be an ECMO center, you need to have experience, there are all sorts of things that go with it that we're not going to talk about today. But that's another way that medicine evolves that is still scientific in many ways. And it was fortunate that it looks like we did good as opposed to not. Other thing that really came up is the power of networks. So this is one example. There were many. There were some international networks. There was huge collaboration around the world in terms of trying to solve this issue for patients. This is called the PEDAL network. After the ARDS network was completed, the PEDAL network was funded by the NIH. This now included not just investigators in the ICUs, it included investigators in emergency rooms to try to capture patients earlier and really think about the syndrome more broadly. This had centers all around the country. You can see based on where the little symbols are, many of these centers were overwhelmed with COVID. So these are not centers sitting somewhere like Vermont. We got really lucky in terms of lucky being a relative term. We were not overwhelmed. Many of these centers were really, really struggling with patients everywhere, multiple ICUs, the whole thing. They were a strong network. They were doing clinical trials at the time. I was the chair of the DSMB for this group, and they turned on a dime to do massive clinical trials in ARDS, in the ICU, despite everything that they were dealing with. So here are the series of trials they did. And the one I really want to point out is the hydroxychloroquine one. Remember, I showed you the dates. We were whipping through, right? It's January, it's March. Here we are. What are we going to do? So they started what's called the ORCID trial. It's in 34 hospitals. They had to figure out how to do testing on these patients, how to get consent when coordinators could not be anywhere near the hospital. They had to get INDs and things from the FDA. I mean, a huge amount of work that you do before a clinical trial, compounded by all these issues related to COVID. And they whipped through it. They were able to, and they're all attending in the ICU. I mean, it's all hands on deck. And by the way, they're doing this. And they actually we got the DSMB together too. We were like, okay. They started the trial on April 2nd, 2020. So remember the dates. They completed it on June 19th, 2020. They screened almost 2,000 patients and they randomized almost 500 and followed the protocol with very tight adherence to that protocol. So it wasn't like they kind of followed the protocol and it looked pretty good. It looked like a very strong, extraordinarily well done clinical trial. The DSMB met multiple times to go through it. And finally, it was stopped for futility because hydroxychloroquine didn't work. That's important. So look at the timeline and look how fast it was. And if we can do extraordinary clinical trials under those situations, now we know we can do it in the future, right? We can start that way. And it's really important because there's actually new literature that suggests when we were using the compassionate use of hydroxychloroquine, just like some other things we did when we were trying to do something and we really wanted to do the best thing, we may have harmed patients. So it's important that when we really want to do something, we say, is there a chance we can at least study it to both maximize benefit and minimize harm? So what are the lessons learned? I love this quote, and it's from an old manuscript, that the past becomes the present. The past is never dead. It isn't even the past. So you've seen here with the history of ARDS where we started, where we got to, where we kind of stood back for a minute, and now we can move forward. And every single thing we do in medicine has a similar history, and there's similar sort of times along the road where things change. The other lesson is that careers don't always follow a straight path. So for those of you in the audience, you may look at somebody's CV and it may look really like, oh, look, she started as a fellow or wherever, and then she became an instructor and then an assistant professor and then an associate, and she's got this part of her CV and it looks like it makes sense. But if you really look deeply, it looks like that, okay, for many of us. So didn't know what I wanted to do, still don't know what I want to do. The big thing is to take advantage of opportunities, pivot when you need to pivot, admit when you're in a situation like a basic science lab of think I'm over my head, but I got something I might be able to contribute, and give it a try. So with that, I'm happy to take questions, and thanks to everybody.
Great. Thank you for a wonderful overview. I have a little PTSD from some of the
Was it enough science for you, Lynn?
I will say March 13th, the day we were declared a national emergency, was the day I arrived in Madison, driving from Charleston with my dog and the rest of my belongings. So,
and I remember that because we were on a ski vacation in Canada with our sons, and we flew back, got in March 12th. And March 13th, everything went to heck, and we were communicating about ARDS or ATS stuff. And I'm like, oh, Lynn has it way worse than I do. At least I'm already here. So thank you for all making her life at least bearable during that. I can only imagine for all of you, but for her in particular, that's a huge undertaking to take on for somebody who's already knows the department, knows where the restrooms are and everything else. So congratulations, Lynn. I mean, just that.
it was Friday the 13th.
Yeah, no, I remember that. It was Friday the 13th because I was running to the grocery store going, yeah, we don't have any bleach at home. I think we're supposed to have bleach. And the last thing of bleach was lavender scented. If anybody's ever smelled lavender scented bleach, you'd probably rather do anything but use that on anything. So.
And I had just moved into the house and like no toilet paper.
Oh, yeah.
So we're going to open up for questions, online or in person. We have questions online. So your description of biomarker research and development is very similar to progression seen in chronic kidney disease. What are your thoughts? I'm just trying to figure out which. And that one. Okay, what's your experience with dissemination and clinical application of a more complicated panel of biomarkers that may have limited availability, with potential limited availability for measurements, I presume, compared to a single biomarker? So
Yeah, and that's why a lot of the work that Carolyn has done has been using biomarkers, many of which are clinical. So, looking at including pulse oximetry, chest X-ray, and some other things is important. And then that is a real problem. So a number of the things we measure, you can't measure at the bedside. You can't measure most cytokines at the bedside. So these are not applicable yet to patient care per se. They're used more for clinical trials. They're used more to continue to try to define the pathogenesis to ultimately, hopefully find something that can be used at the bedside. We did a lot of work also. So as a clinician, I was like, it's not just the lungs that are failing, like everything's failing in ARDS. So we did a lot of work looking at kidney function and biomarkers related to kidney outcomes. They also have the same problem with definitions, like what is acute kidney injury? How do you measure it? What do you do with somebody who's doesn't making urine? So it's a complicated process. It's just not ready for the bedside.
And maybe I will ask for a follow-up question and then you can go to Farah. So, we measure biomarkers, we see it's elevated. We often make an assumption that an elevated biomarker is a bad thing. So we should be targeting that. Do you want to talk about?
Yeah, so we always think it's a bad thing. So it turns out some things are good things, right? I mean, there are biomarkers that are anti-inflammatory. So you'd like more of those, not less of those. There are also biomarkers that go up that we're not even quite sure, are they always good or always bad, right? So we assume that something, so if there's several things you can infuse into animal models or put into a petri dish that cause lung injury. But maybe if they're there with a different set of biomarkers and in a different milieu, they may be protective in some way. So part of it is when we identify these, we don't completely understand how they work. We don't know all the mechanisms. And so you measure one and you're like, oh, that must be bad. And then you're like, okay, we're going to give them something to make it go away. We'll do anti-TNF. And anti-TNF doesn't work. So does it not work because you didn't get to where you needed? It didn't get to the lung, for example. Or did it not work because TNF really isn't your problem, that it's downstream, upstream, or in a totally different stream? And that's a continuous thing. It makes life interesting, right? Because you can continue to study things, but it makes it really hard.
Thanks for that really interesting talk. A lot of the science went over my head, so I'm going to
That's
ask
okay.
you about
That's
how you got involved with AAIM, because that seems like quite a different thing than what you told us about.
Yeah, that's pretty different. So along the way, so last night people were like, so what about these other parts of your CV? And I wasn't quite sure how to incorporate that into any talk. So I've had the privilege of doing a lot of different things in my career, partly because, if you're in a basic science lab and now you're in the clinical arena, you're like, oh, maybe I should do more over here because I'm comfortable. And different opportunities came up. So one experience I had is, so the Alliance actually has there were 5 separate organizations that came together. One's called APM, it's the Chairs of Medicine. So early on, I was part of that group and part of their executive council. I then went on to do what Lynn has now done, which is get to be the president of the American Thoracic Society. And that role is not too dissimilar to what I'm currently doing. So I had no plans to become the president and CEO of the Alliance or plans to do any of that. I was the chair. So in Vermont, chairs are chairs for a really long time, okay? So I was chair for 16 years, which seems like a really long time, but many other chairs have been there for 30 plus. So I was still kind of a new chair, which is a long time. So there are problems with that. So first of all, it means that there was no opportunity for anybody else to be chair, right? And I had already gotten division chiefs, and there's really not a lot of opportunity for the department. That's really not fair. Can I say I took that into account? Not as much as I should have. And then, COVID came along. There's no way as a chair that you're going to leave in the middle. And then we had a cyber attack and some other things. So I was not looking for anything, but I had had this experience with the American Thoracic Society, which really gives you a lot of leadership experience. It helps you sort of understand the bigger world of medicine, and a lot of international experience as well. And I had been part of this the AIM in the past. So I knew the person that had the job. I knew he was retiring. I live in Burlington, Vermont, outside of Burlington, Vermont. I love Vermont, never wanted to leave. So I didn't look at the job. It's a great job. I was like, that's great for somebody, not moving to DC, not looking at it. Somebody finally called and said, have you read the job description? I'm like, not moving to DC, it's not gonna happen. And it said specifically for the right candidate, relocation might not be required. And at that point I was like, that looks really interesting. I would love to do that. I hadn't been thinking about that. But it provides me with a new opportunity with something that I know kind of how to do, although I'm learning plenty as I go, as you do in any new job, and I get to live where I love. So that's how it happened. But, you know, there was somebody last night said, how did you end up being like president of the medical staff? Like, where did that fit in? And that's a good example of you should always ask questions before you agree to do something. So I was the chief of pulmonary critical care. I was attending in the ICU. I was down at my office doing something. I got asked to come back quickly to the ICU, not stat, nobody was resting, but could I get up there? I'm like, sure. So I go up the back stairs and I'm kind of, you know, not running, but I'm hoofing it. And a colleague comes into the stairwell and he goes, you got a second? I goes, about a second, but I got to get to the ICU. I don't really remember the conversation. I think the word medical staff might have gotten mentioned. There was something about, we need some help. I'm like, happy to do whatever. I was still relatively new in the organization. I'm like, sure, if you need something, just let me know. Apparently that was enough that my name got put in front of some committee. And the next thing I heard, I was the president of the medical staff. So, and it was actually an amazing experience. So I was kind of like, I don't even know what that is. Like, So that gave me a lot of skills and oversight that I had never had the opportunity to do. So president of the medical staff sits ex officio on the hospital board. President of the medical staff, you know, is ultimately the one who makes sure that credentialing happens for everybody. And president of the medical staff is the one that when there might be issues with a provider, which is everybody's favorite activity, that's the person who gets to manage that. So you can learn things in everything you do, but I would highly recommend that anytime you get asked to take a new role, you go, so tell me what that role is. Tell me tell me what resources I have. I'm always surprised at people that get asked to do new roles and they go, sure. And then I'm like, do you want to know, like, do you have the tools to do this? But if you don't want to know that as a chair, I'm fine giving you the job. So make sure you really ask about things, but don't say no just because you haven't done it before. Because if you hate it, you don't have to do it forever. If you love it, you're like, oh, this was great. And if you're sort of like, I can do this for a while, and then you pass it on to somebody else and give somebody else the opportunity.
Probably a wonderful way that you weave together actually two themes and question. Obviously, as the complexity of this research has evolved, and as the thinking about phenotypes and heterogeneity and biomarkers, you had to probably engage new people into your team to be able to measure the things you needed to measure. So, I'm thinking even now how AI and other matters are going to analyze this data in ways that we can't quite understand. So any thoughts about how you kind of built this evolving team to be able to accomplish your efforts?
I think the thing is to readily admit when you have no idea what you're doing. And again, it's everybody, there are many times when you'll be an attending in the ICU and you're like, I really don't know the answer here. Say it, okay, go, I don't know, and then start to figure out who might know. And also think about who you can work with. So we did a different project that I didn't show. There's a lot of stuff that starts at the bedside, never really gets translated to clinical therapeutics, even though there might be something that's in the clinical arena. It's called kind of the valley of death. And there's a way to get through that, but you can't really do it as a single investigator. You need a lot of other people. And we had an experience of putting together things in Vermont. I put together a program where you actually started to look and say, what other people can be helpful? So you look at the problem And then you're like, so it turns out, the business school was an amazing resource for this. There were people in the community who had experience with certain things that we could bring to the table. So just sort of thinking broadly about, okay, here's the issue, here's the kind of resources we need, and look outside your own little world. So, I was pretty much in the pulmonary medicine world, and I loved everybody because I'm chair of medicine, but that's still a very defined world. You're sitting on a main campus here. There are huge resources and opportunities with people there are people in humanities, the arts and sciences group, who have major things to offer in terms of how do you communicate things. The business school, how do you make a pitch? Like, how do you stand up and tell people about your work? Because they're used to like pitching to venture capitalist type stuff. That's a short elevator speech. We're really bad at that scientifically. Are there people who are figuring out new ways to analyze data, especially like in environmental sciences and things? They have billions of pieces of data coming in, and they've created really great new models that you can use in medicine. So for me, that was sort of the eye opener. It was like, I don't know how to do a lot of these things, so let's figure out who's out there beyond our own world. And the NIH is really starting to support that, the team science concept. And we all do it as practitioners now, as we practice clinical medicine, right? We don't do it by ourselves like we used to. It used to just be you taking, a little, well, I never had a black bag and went to somebody's house, but it was a one-person show. We all work in teams, but think about broadening those teams out for everything you do. It's really fun. And it's really fun to see how other people think and have them go, I don't know what the heck you're doing. Like, try this. That's great.
So maybe I'll ask the final question. And in terms of your career, you presented and you have had an amazing career and touched all facets of medicine. Do you do it all at once? You have
Oh, no.
research,
No.
clinical work, administrator. How have you balanced or modified your effort allocation over time?
So you might want, my husband's a psychiatrist. You might want to ask him because he's not quite sure I did it very well sometimes, but which is why our kids look pretty normal. They have critical care, psychiatrist, and they're in the middle. So they lucked out. So I have not been great about work-life balance all the time because it's really hard. You get asked to do something, there's 7 things and you kind of get them done. But there were things that people told me I had to do that I knew I couldn't. So I have 2 sons and I really like spending time with them. They're adults now. I still love spending time with them. And when they were little, I like spending time with them. So early on, it was like, if you're in the tenure track, that was the only track, you've got to get promoted. There's this up and out. You need to get a national, international reputation. You need to start going out and giving talks. I'm like, okay, but I didn't really want to travel a lot. I didn't like leaving home. I was happy, if there was something the NIH needed, that seemed important. Giving a lot, being a visiting professor, a lot of places was just going to be too much. I just couldn't. So I was like, well, maybe I won't get tenure. That's going to be bad, but there's got to be another way. And there are plenty of ways to do it. So I didn't travel. ATS leadership opportunities, people talked to me about it. And I was like, no, I have kids. I'm not spending a couple of years traveling around the world and trying to manage things at home too. So I put things off intentionally, primarily related to family. And then there were other things, chair of medicine comes along, it gets really busy. We were becoming a network and 9,000 other things. And so you're like, eventually I can't attend in the ICU. I just can't be in 2 places at once. Vermont had a lot of things happening. So you have to sort of do things sequentially. So you start things and you stop things sequentially. I've not been really good about mapping things ahead of time. Other people are better about that. But don't let anybody say there's only one career path, and if you don't do X, you're not going to make it. There are a couple things you kind of have to do, right? If the path says you have to get an R01, then you have to get an R01. Or if the path says you need to be an outstanding clinician, you need to be an outstanding clinician. But that doesn't mean there aren't a lot of ways to get there. And you can make almost anything work. And the advice I have for everybody is I sort of think about it this way. We all have a million balls in the air, right? There's always stuff up there. There are a few that are made out of glass. And for each one of us, those are different. And the glass ones you can't let drop, because if they drop, you've got a problem. But the other ones, if they drop, it's probably going to be okay. So, there were days when I looked at my sons and went, I can't believe they're wearing that to school, but it's not going to matter. And there are things like that happen in medicine too, right? You just kind of have to let some things go, but don't let the really important things go, and know what those are to you. You'd have to make sure whatever your glass balls are, that they stay in the air. So have fun. That's the most important thing.
Great. Well, thank you so much.